this morning as well as be our speaker for Grand Round. So with that, I'll let him begin.
All right, good morning. Thanks for coming so early. So Prelude is one of our studies that we are starting as part of a really extending program in our mitral valve space. As you know, for a long time, any kind of mitral valve surgery was really the domain of cardiovascular surgeons. Then, for example, the MitraClip came, and for structural heart disease, at least for the primary mitral disease, there's at least an option now for inoperable candidates. But the mitral space overall was still very difficult, and I don't have to tell you new things here, but it is very difficult to treat the mitral valve. The surgeons know that, specifically the functional mitral valve disease. And so there's a couple companies and their feasibility studies coming out now. And one of them is here Prelude, which is, I think, an exciting space or study. And this particular study is a study with a device that we can put in through a transseptal procedure. So it is basically like a Lego system, right? So you have one kind of annular construction that kind of sits in the annulus, and then the second part is actually a valve that fits into the first structure that you put in. It's obviously also a complicated procedure, and we haven't done any yet, but I think the way I understand it is we probably will be able to do the first one in April. And here you see criteria. They're always often the same. I always say don't think too much about it. If you have severe MR, a patient that isn't really a clear-cut surgical candidate, let them just be evaluated by us, because at the end of the day, we still have to go through so many exclusion criteria that we don't even mention here. But just if there is someone severe MR, you don't see any other option, surgeons have declined, or they have been going through the valve clinic anyway, then I think this might be a great new option for patients. Obviously, very difficult to treat, but we'll go there. In 5-10 years, maybe we have different talks with good outcomes. All right. Good. So then my talk today, and thank you for giving us the opportunity to talk about this, if it works. There you go. I'm really proud, actually, that we were able to do something like this. We haven't started yet, but as Dr. Moody pointed out, there's some problem here with the twin cities, obviously. That's on purpose, because you can see that there's a V in the valve, right? So in collaboration with Edwards, we will start a small, but nevertheless, first-time nationwide study or research, I would say, where we will try to evaluate what is wrong with the disparities in structural heart disease. And once we started thinking about it, and actually the idea that we had came from more the PCI area where similar studies are going on, and I have to say, coming from Europe, it's still something I absolutely have to read about it and understand, because we don't have the same disparities or different ethnicities, for example, in Germany, right? So this whole question of, why should there be a disparity is, for example, for me, absolutely new, totally naive to it. So the more I read about it, the more I have to say, oh boy, right? That is something we really have to try to address, and obviously we're not the first one. So I will give a talk about, hopefully it's to try to focus on a little bit on structural heart disease and the problems we have there. But I have to kind of always rein in kind of the nationwide problem that is out there in order to understand why we might see the same, obviously, in structural heart disease. So at the end, I will also present the aims of our Twin Cities study. And really, this is aimed for assessing the problem in TAVR and disparities. So first, this definition here. So healthcare disparities are differences in healthcare quality, access, and outcomes adversely or adversely affecting members of racial and ethnic minority groups and other socially disadvantaged populations. And the funny thing is, for me, funny, not the right word, but if you look at the quotes, it's like 2012, right? So it seems like when you read the papers about it, most of these interests into actually forming a national committee on it is around 2000, 2002. So obviously there's more literature, and I'm not even a third through it, but there is somewhat also for me a concern that this is something that all of a sudden we kind of think we have to address, which has been probably a problem for 50, 60, 70, 80 years, and so on. Now, if you look at the distribution of I call that more than average racial ethnic minority population. So what this paper did, they said, so on average, right, we should expect in every state, I have a pointer too, I think. For example, about 16% Hispanic Latino, which is an ethnicity, not a race. African Americans, about 13, 14%, and 5, 6% Asians. So if you take, those are basically the states that are in white where you kind of expect the same distribution. And then anytime you see a little bit more than that average, you have a color code. And as you can see is, more so in the South, we start to have color-coded states. And that goes from, let's say, a mixture of Hispanic African Americans in this area into more a mixture, of Asian and Hispanics here, and then more in African Americans and Hispanics down here. When you then look at a different paper, and you see preventable death rates, and I can toggle back and forth, and you can correct me if I'm wrong, but the color codes of preventable deaths, which means the darker green it gets, the more preventable deaths you have, is almost following exactly the same pattern, right? And why is that? Then, if you look at overall distribution of race and ethnicity, again, Hispanics are considered an ethnicity. 62% in 2015, this is nationwide, U.S. 62% should be white, 18, 12, 15%. Here you see the distribution. So the next highest is 18 is Hispanics, 12% blacks, and then 5 Asian. In Minnesota, in Minnesota, you should have a little bit more in 2015. This is actually, Ross helped me with this, 77% whites, a little less Hispanics, also less blacks, but a little bit more Asians. But so this is the Minnesota distribution, basically, you should expect. If you then see projections into 2045, you see that all other races other than white will increase, at least by projection. So 25% Hispanics, blacks will be almost the same, and Asians slightly increase, but especially the Hispanic population will increase, which in 2050 then is projected that the U.S. for the first time will be a non-white majority, which is interesting, right? And I think you heard a lot of talks on various channels about this now, how some people might get afraid of that. If you then look, so that's just a distribution of, let's say, often minorities and different races, right? But so is that really a socioeconomic problem? Well, the problem right now is that only 11% of Caucasians or whites are not insured, but we often see a lot of Native Americans and Hispanics not being insured. Another problem is that, which is also interesting in the literature, that a lot of minorities, when they're less than 65 years old, they're totally unaware of their options, like, for example, Medicaid. Yeah? So they have no idea how to actually handle an uninsured situation. This is, again, Ross helped me with this, and we can always update that as I go. But in Minnesota, in our region here around the Twin Cities too, we see basically the same. So often Hispanics are under or not insured, American Indians too, Asians, and blacks as expected from the other statistics, almost the same, but a higher rate of Hispanics not being insured. And that obviously is a problem, which is interesting. There was this, and I don't want to be political about this at all, I'm just reporting things. But for example, in Europe, in England, there was just something recently, right? A lot of criticism about that English NHS system, but there is really zero non-insured, right? So there's countries in Europe, there is not a person that is not insured. It's just a matter of, how good is your insurance, maybe, for sure, like in Germany, right? I mean, I can have a luxury insurance where I can say, I only want to be treated, by Dr. Pulup's, because he's the boss of cardiology, so he comes and sees me and leave me alone with other people. That's a luxury that you might want to have. You still get the same treatment as someone who had a lower insurance because overall the hospital treats you kind of the same. But it's not really possible you have no insurance, right? Because that's really a problem. And I will talk about that more with another statistic later on. Now, I'm trying to now kind of weave in the structural heart disease. And if you look at an English study here, this is Oxfordshire, I think, study. They basically looked at valvular heart disease and how this would develop in the next years and how it's currently prevalent in different age groups. And they looked at people more than 65 years old. So you can see that newly diagnosed moderate and severe heart disease obviously increases in the age groups more than 65 years old. When they then look at the prediction of undiagnosed severe heart disease, it's going to increase significantly. So less and less people will potentially seek appropriate medical care, but it's going to be a big issue. What you're going to see is a lot of AS with its combinations. Second highest will be mitral regurgitation with its combinations, but that's pretty well known. We always know aortic stenosis, mitral valve regurgitation, and aortic stenosis is going to be the biggest factor. Now, the next problem that they also saw, and this is again an English study, is the undiagnosed severe heart disease is mostly prevalent in people, again, in minorities and underinsured. Right? So what we're going to see is that we have a growing minority population with uninsured people and increasing valvular heart disease. Right? So we have to fix that somehow. Right? Now, how do we do right now? So if you look at different registries, and this is 2017 or 16. So if you now remember that we should have about 70–80% whites and then 13–15% Hispanics, same for blacks, and maybe 5–6% Asians, right? You would expect, if we assume that the mitral valve disease is the same in all groups, which you could argue about, and we'll try to get that, but if you try to assume at least it's similar prevalence, you should see the same, right? So you should see the same distribution of races, you think. But you really don't, right? So we see, for example, here in Abbott Northwestern, we treat almost 100% white people. Nationwide, we treat like 88%, and then you see a little bit distribution here, but certainly not in the groups you would expect. Yeah? So what's the problem there? Watchman device, yeah, we have everybody here. Same thing, kind of. So you see that you have 1% and 5%, right? So, and then where did we see? And the rest is the whites are again in the 90% range. Right? AVR, just aortic valve replacement without TAVR right now. So by the STS, and our dream, Danielle, helped me with that. You see again about 90% whites and then really no other distribution. If you look at Abbott Northwestern, we have nobody treated in, for example, the African-American population 2017. TAVR, same thing. So this is actually almost the same numbers at Abbott and the TVT registry. Again, we have over 90% whites and almost no other participants. in other ethnicities. So the only explanation you could have if you don't assume it is a disparity is that the other races and ethnicities just don't have AS, right? So that's the only explanation, right? And actually there are some people who say that, right? So there are some people that say, okay, there are data, but we'll go through those data. There are some indications, some papers, actually not very easy to find papers that really look at races, ethnicities in particular, but there are some. And for example, there's this paper who says that the early onset of aortic stenosis in African Americans is increased. But then if you look at the prevalence, it's really equivocal. It's really hard to find a definitive paper on that. For example, in 2001, someone did, I thought, a really good study, Aronov. They just looked at over 60-year-old men and women in different races and ethnicities. And they really found aortic stenosis, for example, to be really similar, right? So 18, 17% had aortic stenosis, not any aortic stenosis. And it didn't matter if it was female or male, you still had a quite similar prevalence. Then you have this paper is very often quoted. I would argue it's not a high-ranked journal. It's not bad, but it's not, I don't think it's a high-ranked journal. But it's very often quoted if you see explanations why, we might not see, for example, African Americans in various STS-CVT registries. And it says that it suggests that African Americans, for example, are at significantly lower risk of developing severe aortic stenosis, right? So this doesn't. So on the one hand, they develop it earlier, but on the other hand, they don't develop it as often. But I think if I review the paper, I think that this, for me, is a little bit of a problem. If you look at a mean age of 45 year old, you can still make an argument, of course, in that age group it wasn't prevalent. And then you see this graph where you say, okay, the African Americans are at lower risk. If you then look at their distribution of age, really, it's in that 40-year-old range, which, if you look at the other English study, you would start to see really severe disease in the 60s and 70s, right? So I'm not sure that I would take this, but we can argue about that, and maybe Paul can comment on this. The same is here, the distribution of male and females, African Americans at 40%, it's also not necessarily the same distribution. We know that the severe aortic stenosis is really male prevalent, right? So something isn't quite right with that study, but it is something you have to consider, obviously. You say, okay, maybe it is just not as prevalent in certain races, right? A pretty good study actually showed that if you look at the progression of the aortic stenosis, in their study, being of African American ethnicity actually protected you from the severe progression, right? So very different results. That when one onset is early, maybe not as prevalent, then progression is a little protected. So there's certainly more studies to be done to make sure that, it might be right that we don't have to expect so many different races and ethnicities in our registries. When I looked through the literature, I came across this paper here, and it was basically a summary of what happened between 2002 and now, so 2016. And so especially in 2002, Congress came together and they recognized that there was disparity, and they said, okay, we have to have an agency that looks at quality research and disparity and give us a report every now and then, right? And so this author here basically summarized certain principles of how this disparity might happen and what you could do about it. Again, for me, and I hope someone makes a comment later, it's kind of interesting that that starts in 2002, but and at least it started. So the principle number one, minority race and ethnicity are associated with multiple dimensions of social disadvantage that affect healthcare and outcomes. And there's some surprising principles in there. So for example, certain minorities and ethnicities are associated with social disadvantage, particularly for groups historically subjected to slavery and forced relocation, right? So I think for someone like me who hasn't been exposed to that, it's like, it's like an aha moment, right? Oh my God, yeah, I never really thought about this, right? So if your family or even before that family members in the distant past were exposed to that, of course, you have a completely different attitude, right, than someone who was always protected. Racism directly toward historically socially marginalized groups contributes to social disadvantage and worse health. So racism is a problem in healthcare as well. And then race and ethnicity are often associated with multiple other dimensions of social disadvantage. So English proficiency, residential segregation still ongoing, limited education, lack of employment and debt, low health literacy and low numeracy, and then poverty. So these are reports for Congress. So if you look at cultural differences, for example, in understanding, historically, most of you went through medical school here. You have talked about the Tuskegee syphilis experiment, where in the 30s, a national study actually was done, where I want to say 600 African Americans were, I think 400 of them had syphilis, 200 had none, and we were part of a study. It turns out that in the 70s, when penicillin was developed, they weren't treated, so they were just observed, and they were never told by any kind of consent form what was actually going on, right? So obviously, if that was something that happened to your ancestors, you would say, am I really interested in a new study, right? I mean, I probably wouldn't. There's overall a higher refusal rate for aortic valve replacement. There's also a lot of lack understanding, if we weave it back to what we do, the differences between aortic valve replacement and TAVR. Obviously, if you have issues with proficiency in English and literacy, so we have to address that. And often in certain cultures, they consider themselves in the 60s and 70s too old, which, I think most of us wouldn't even consider anymore, but they simply say, I'm 60 years old, I'm ready to die. So that's something, either you accept that or you have to maybe even say, well, look at what we can do nowadays. And then often we have group decisions versus individual decisions. Mostly, when we see, I think, our 70-year-old, 80-year-old white person, most of them will make, their own decisions, might talk, to their wife. But often, minority groups, actually, they come together as a group, and there might be even a high-ranking family member, so to speak, who makes a decision for the whole group. Right? So you have to kind of figure that out sometimes. Second principle, healthcare disparities arise from the failure of healthcare systems to respond to the needs of socially disadvantaged patients. Again, these are findings for Congress, right? So this is ongoing. So there's little policies that make system failures happen. Health systems might fail completely. Teamwork and care processes fail, and clinician behavior can also be a problem. And here, equity in healthcare implies healthcare is responsive to the unique needs, culture, and preference of patients, right? So I think we're definitely failing in that. And of course, overall, equitable healthcare is the hallmark of a genuine patient-centered care. So if we talk about patient-centered care, we probably have to weave in somehow the different cultures as well. So how is that, for example? If you look at the same report, how different races, ethnicities feel the quality of healthcare that they receive. For example, if you just look at poor versus high, right, income, you can see, and this number here is not the percentage, this is just the number of patients or groups that were interviewed. This is the percentage here, but again, this almost is the same. So about 60% of the poor feel that they get worse health care than the richer people, right? About 30% of the blacks feel that they get worse health care than white people, right? And so on and so on and so on, right? So this is something that actually has improved over time. But again, I think all of these numbers, I mean, ideally, obviously, shouldn't be that way, right? I mean, there's always going to be a little difference, maybe, but I mean, there shouldn't be, right? You shouldn't have a disparity between different races, and ideally also not with income, right? Number 3, social disadvantage is associated with worse healthcare access and affordability and lower quality care, right? So it just gets worse and worse. Being uninsured, underinsured, and unable to afford healthcare is, of course, an issue. We know that. Geographic structural barriers can be a problem, particular to primary care, and we'll get back to that, because we all are very dependent on primary care and on the referral. Some practices don't accept Medicaid patients. And many U.S. hospitals still have a dual system of care operations. This was 2016. So I didn't know about that, for example. I hope I never worked in a hospital where that actually happened. But I don't know. But it seems like there are some hospitals that decide that staff treats whites and residents treat underserved. That's still ongoing. So, I mean, you can have a situation where the staff is busy, right? And we do that too, right? And we just have a very good fellow treating a patient. I mean, it happens, but to actually have a structural decision, I think it's just unbelievable. So I hope we don't do that here. I don't think we do, and I hope never ever where I work was that an issue. Then, of course, when we go to the insurance issue, we all know that, and again, we don't want to make this political, but this is a Congress report. So you see that obviously there's a disparity in health insurance. So, for example, as we know already, Hispanics have a high uninsured rate, blacks as well. Whites also not perfect, right? But they are at least the best of the group. And then there's a change that happened around 2013 where everything got a little better, especially if you look from the 2010 mark. And obviously what happened here is that during the Obama administration, ACA was introduced here and came into action in 2013, and then it got better. Right? I mean, it's just a fact. This is really a fact that I'm still trying to understand. So 47% of our fellow Americans, and this is just everybody, are not able to cover a emergency cost of $400, right? So that's, again, a Congress report. Now, when we sell insurance plans, often the high deductible plans are a favorite, correct? And I think many insurance providers prefer that. Less than 1/3 of that deductible is that amount, basically. So if you have an insurance with a deductible, you're not able to pay actually 1/3 of that deductible. So how does that work? So, I mean, if there's 50% of people that can't afford an emergency visit for $400 without borrowing money, how can they ever afford the deductible of an insurance plan? How's that ever going to work, right? We won't change that, but maybe we can at least advocate for it somehow, because this is not going to work, right? Then constraints on clinician-patient decision-making affect healthcare disparities. So, for example, there are certain reflexive decisions by various groups, but we have that in every group. I never take the flu shot, I just don't, right? So you have to kind of work on that and try to help correct these reflexive decisions, habits, or deliberative decision-making. And of course, if you don't have resources and you can't afford it, you make certain decisions. So it's all, coming back, of course, that we have to find a way to even make healthcare affordable to patients. There are interesting things with accessibility, right? So, for instance, this is an interesting study. A lot of studies are focusing on African Americans, which is interesting because the highest group of ethnicity and problems is actually the Hispanics. So I think there should be a lot of studies on that too. Hopefully that's coming up. When you look at the proximity of African American families to high quality hospitals, and that is ranked by outcomes, all the things that you can read online about healthcare outcomes. You see that, for example, for bypass surgery, abdominal aortic aneurysm, those are 3 examples, lung resection, that a good amount of African Americans are actually living closer to good ranked hospitals than whites. That's just a fact, right? When they then choose, the same people choose the hospital, for some reason they don't want to go to that high ranked hospital. right? So they go to the lower ranked hospitals. So they're more comfortable, or I don't know why, they go to the other hospital, which is interesting, right? So there's, again, a disparity there that isn't quite explained. Maybe we can talk about that, why that might be. And then there's biases that produce healthcare disparities through multiple pathways. So we all have our biases, and there's this implicit bias that can affect legislation, policies, and allocation of resources within an institution. And then there's also physician implicit racial biases. So you see less patient-centered communication, less informed decision-making with minorities, and how much information a physician shares with a minority patient is also different, right? So, and we can talk about this, why this might be. Is it more difficult to talk to someone who is not speaking your language, someone who doesn't have insurance? Does that bias you immediately? You know, that's the question. Definitely leads to certain disparities. For example, here the referral disparity in African Americans again. So the lesser income, the lesser referral for TAVR. Just the income basically determines whether or not you're going to be referred for the newest therapy. Overall, African Americans are less likely to be referred to cardiology. They also are less likely to accept an intervention that comes back to like previous experiences with studies, for example, in your culture. And they also don't come for follow-up, or less likely. So overall, if you look at what happens after you did an echo and you found severe aortic stenosis, being African American, for example, is a risk factor for not being referred, for declining, for not having a follow-up, and for actually being referred for any kind of interventional therapy. Yeah, so it's just an unknown. We probably come up with, anybody can come up with a reason, but it's just fact. And there's principle 6, differences between and within geographic areas. Healthcare organizations, physicians contribute to healthcare disparities. So there's different types of healthcare disparity. For example, between providers, it's called a type 1. Within providers or provider entities, for example, within the hospital can be type 2. And then Medicare or minority medical patients continue to be cared for more often by trainees rather than by staff physicians within hospital systems. So that's coming back to what I said before. So again, there are issues between entities within, for example, a city, and within an entity like, for example, our hospital. And those, if you want to fix it, have to be addressed as well. And then number 7, there's a continuum of relative proximate influences of clinician and patient factors on disparities. So number 1, there can be a type A disparity as a clinician factor. For example, if in the beginning you didn't have order sets, what was observed is that certain people would get DVT prophylaxis and others not. And it was more likely that you as a minority wouldn't get that, right? So then to correct that, you just made it mandatory to have a clinician support system in your electronic record, and so everybody gets the same. So that's how you can correct certain biases that might exist. Type B, adherence. So that's a big problem, and it's, you know, multifactorial, as I point out in all these principles. But for example, as an adherence problem, you could try to eliminate certain co-payments, and there's other ideas that I will come up later. And then communication. So that's a big issue, of course, too. How do you address disparities or issues that come up with communication? So how do people, different races, experience communication? I mean, not even, white people also don't feel always perfectly engaged with the doctor, but you can see that blacks and Hispanics definitely have a worse communication. If you just look at the Hispanics, then that communication, again, even depends on their income. So those who have a higher income somehow have a better communication. Maybe that has to do with education, how they are approached. But again, there is that disparity that has to be fixed. No-shows. So any kind of racial, or if you're part of any kind of a minority group, that's except for Asians, is really highly associated with not coming back for an appointment, right? And in this paper, people were saying, okay, how do we address that? Obviously, you can also make that argument for a white patient, right? So it's not like, okay, now we're going to leave the whites completely alone. But especially for other minorities, you know, do you have to have more walk-in access? Do you have to re-engage in home visits? For example, Germany has a huge access to home visits, right? Every doctor has more home doctor practices, and they just at 2 o'clock, they close their practice on 2 days during the week. They go in their car and they drive around to patients that just do not come to the office, right? And I think that's something, I don't know, it has to be addressed. It's a suggestion, but I think it might be worthwhile exploring. And of course, that's what we already do, electronic visits. So can you do any kind of video conferences with patients and not have them drive into the city because basically they can't even afford getting a taxi or any kind of transportation. Rehospitalization. So you also see, especially in African Americans, that there's overall a very high rate of hospitalization. But often, rehospitalization also occurs in very avoidable causes, like, for example, we know CHF, asthma, diabetes. So again, that's an educational problem, not coming back to your home doctor. So as you can now realize after so many slides, there's just a conglomerate of problems, and you have to address them all together to really fix the issue. As an example, how can you improve medication adherence? So there are some different engagement strategies. You can open up patient portals. There's some smart apps that you might be able to use in some patients. Digital pill boxes are pharmacist-led engagement. Cardiac validation is very important, but of course you have to make sure that people can actually come to it. And then cognitive behaviors with interviews. Number 8, healthcare disparities can be successfully addressed. So, for example, if you remember this inter-entity disparity type 1, if you have universal quality improvement projects, then of course you can address that. Within an institution, you can do targeted quality improvement projects. For example, communication, right? So you could do a quality improvement project, Abbott Northwestern, how can we do better communication with minority groups and address that. The sustainability depends on implementation of factors, acceptability, adoption, appropriateness, feasibility, and cost, level of integration into routine care and continued organization priorities. So how to fix it? So we have to ensure that equity requires systems or optimize the core elements of primary care. And I think at the end, really it comes back to primary care. And when we give talks, and I will show one of the slides later, that's really, I think, the main focus it should be. I mean, of course, we have to improve our care as well, but if it already fails on the primary care level, I think that's where it starts. So accessibility, continuity, comprehensiveness, coordination, whole person accountability, particular informed and shared decision making is important. And there's really a focus on this output here in 2016 that you have to create culturally diverse, multidisciplinary healthcare teams, and especially in the primary care, but I think that's also important for other groups like ours too. And that comes then, I know that the last like 4 or 5 talks are a little boring because it's like, okay, you kind of know about it, but I think it was important that Congress and this agency puts these different problems into words, right? So we kind of know about the problems, but how do we name them, right? And we can't address all of them at the same time, but with the fact that when we look at the STS registry and we have a huge disparity in treatment of minorities with, for example, TAVR, what we decided is to look at TAVR by itself and our valve team and collaborate with HCMC. Dr. Zingman over there will help us. And what we will try to do is try to figure out how can we address that disparity just with aortic valve replacement and TAVR in the Twin Cities and with these 2 institutions. So again, the primary health care team is of course always number 1. So they have to be seen by someone. The first conversation has to happen there. And if that conversation fails, obviously you're never going to see that patient, right? So all of these principles that I just discussed, you have to find out how did that potentially influence a non-referral to cardiology. Then, you know, could we fail by seeing a patient as a cardiologist and then not refer to aortic valve replacement or TAVR, right? Could we have some sort of biases that make us not refer disparity patients? And then even if they are referred at the end, is there may be some sort of bias that they still don't get the treatment that they're eligible to. Big project, but we focused it really on a few. So these are the aims of our Twin City studies. And again, we have to thank Adherence for the support of that study. I hope in the next couple of weeks we can start it. Lots of people have helped here to get this going. I think we had a, Dawn, correct me if I'm wrong, here. How many months of IRB review yeah. So just the IRB review on a questionnaire that we want to send took like 6 months, because now all of a sudden when we got the reviews back from the IRB, it's like, for example, why don't we treat everybody? You know, why is this problem? And why don't you translate things so that they better understand? And so you go, well, for the last 100 years that hasn't been done, yeah, but now you want us to do this, right? But we did. So we will translate everything. We will make sure there's interpreters, and we will address that problem, try to make sure that there is not any disparity. And I think that's the IRB's point, right? They say, okay, we have to kind of eliminate the problems that there might be. Okay, so what we will do is we will look at our databases, but we are somewhat biased, as you can tell, with an 89% patients only white. But as you know, that HDMC has a much more diverse group. So they will look, and we will look at 30,000 echoes in each reporting system. We'll find out who did not get guideline-driven aortic stenosis therapy or did not show up for follow-up. Those patients will get invitation letters and phone calls to come back for a clinic visit. They have a choice, obviously, but hopefully they come back. And then we will discuss and educate the patient, referring, and the cardiologist with many talks on TAVR and outcomes, and hopefully we can address that educational problem, communication problem, right? Then with questionnaires, we'll try to find out, and we had to limit the questionnaires not to bore people, but at the same time they had to be expansive to actually try to get to it. So we'll try to see if comorbidities, race, ethnicity, the language barrier, or your status has an impact on disparity. Also, did that make a difference in aortic valve replacement or TAVR? So patients and providers, as soon as they're identified, they will get this questionnaire. And then at the end, once a certain number of patients are treated, we'll also try to compare outcomes, right? So far, outcomes in TAVR between races and ethnicities are not different, right? So it's not like, you know, Hispanics are dying more from TAVR than white, for example. So there's not any problem really in that regard. Good. So it's a complicated topic, obviously, but again, I'm happy that we can at least start some sort of project to try to address the structural heart disease issue that there is. And any questions or ideas how we could fix it?
Dr. Goessl, excellent talk. Thought-provoking, very thought-provoking. If you were to divide the white population into terciles by income, does it start reflecting some of the other populations that you've put out there?
That's a good question. I don't have a slide, or, you know, I ignored the whites. So, which is the problem, right? So, yeah. So, I mean, I think, you know, from what I know, that is true, right? So, obviously, any kind of income and educational problem leads to some sort of disparity then as well. But I think based on the fact that there's such a huge disparity between, you know, whites and other races, of course, we were trying to focus a little bit on the minority groups at this time. But you're right. I mean, it affects everybody for sure. And ideally, you address it all, right?
Thanks for a great talk. about the current study. There are language barriers, and then there's also literacy barriers. So how are the patient questionnaires going to be done if people can't read or can't read English?
That's totally good point. So everybody who gets this questionnaire has an interpreter sitting with them. Right? So if they can't read, then they're going to have someone read it to them. Right? So, and the same thing you can say, okay, how do they understand a letter, right? If you send them a letter to the mail, but if they don't respond to the first approach, which is a letter, they will get a phone call in their language then, right? So we're trying to really get to the problem. Of course, then ask the patients who had that barrier, was that really the barrier that you didn't come back, or did you not understand? Is that the problem really? I think that would be then easy to fix, hopefully. But you're right. We have to make sure, and I think that's definitely the IRB's criticism in the beginning. We have to make sure that we, don't bias ourselves now by not talking to anybody who doesn't understand us.
And then I guess I should know this, but what's the status of the TAVR program at Hennepin compared to our program, and could we treat patients that they see if they need help with more challenging cases?
Yeah, so how much can I say here? I'm not sure. I want to be careful. Let's put it like this. So there is a program that has been there for how many years? 5 years? 6 years? I want to say we collaborate with them for many years. And for some reason, we haven't figured it out. That's the bottom line. So I think the study actually also gauged that interest again, right? To say, okay, what did we do wrong, right? So how is it possible that we have almost no referrals from the group that doesn't refer to anybody else, right? What's the issue? And I think that's our problem too, right? So we have to figure out, how can we make all of these pipelines much, much better?
Are they doing the TAVR?
No, we would do them. We would, yeah.
So, Mark, first of all, great talk. And it raises the question, if you just look at isolated institutions like a teaching hospital, urban setting, is the therapy just not available? And in teaching settings where you have people who are at variable levels of understanding what's even available in their own institution, like house staff, is that one of the barriers? So are we looking at institutional barriers like that as well? Because I don't know if it's fair to compare apples and oranges of Abbott and Hennepin, right?
Yes, absolutely. So part of the study is really to go out, make sure that within our group we know all what's available, because sometimes there are surprises too. I think we are super good, but if you go through the hospital, you might still find someone who doesn't know what TAVR is, right? And that option is not there. In many referring institutions or referral groups to Hennepin, there's definitely a lack of knowledge about the options in primary care, and that's one of the principles, right? So we will go out with Mengistu Singh Men and target 10, 20, we'll see how many let us come, groups. 10 are already scheduled, like different healthcare groups, primary care groups that specifically treat minority patients and tell them about TAVR, tell them about the option of Hennepin, which they refer patients to anyway, not to us, as you know, there is that, but at least through Hennepin that option is available and to educate people. And then within the group of Hennepin also, right? I mean, and here as well. I mean, I'm not saying that we know it all, but at the Hennepin group for sure that we readdress that pipeline that is available, right? So primary care, better referral to cardiology, then cardiology also being aware that that pipeline is there, and make it easy, right? So if you have a patient that has TAVR and you make 10 phone calls to get the patient over to TAVR, it's never going to happen again. Like, I mean, you would do the same. So we just have to address all these principles in different ways. And I will do a little like this, and maybe it leads to something bigger. We'll see.
So the second circle of challenges was going from cardiology to a TAVR specialist. Did you guys define who is a TAVR specialist in this study? If hospital does not have a program, does that mean that if they don't send these patients to Abbott, that fails this step?
So you know, this graph that I showed is just a kind of a general graph of how things should work. I mean, right now that step fails.
Did you define in this study, who's a TAVR specialist? Like,
so for us, for Hennepin,
for the entire study, I mean, it's a study.
yeah. So for us, we can only do the study in Abbott and Hennepin, right? So for these two, it's us. We are the TAVR specialists. Yeah. So if we fail to, you know, deal with these principles, yes. Yeah.
Thank you, Mario. I wanted to ask about cultural barriers to intervention by age. I know your aortic stenosis patients are commonly of more advanced age, but my experience has been when you talk to patients, especially patients who don't speak English, there's cultural barriers to the intervention, but there's also sort of an age-related barrier in that you can have the children of an older patient who is a candidate for an intervention, and the children understand it in English and in their own language. But it's very difficult to impress upon the person who's the candidate for the intervention the benefit and the, you know, even the particulars of the procedure. So it seems like there may be an additional barrier just based upon age.
Yeah. One of the slides, and that's actually, I mean, that could be a whole own talk, I think. There's definitely that cultural difference that, like you point out, there's certain cultures where if you are a certain age group, you don't want to have any, you know, specific and fancy treatment anymore. You think, okay, I have cancer, I'm 60, I'm dead. So basically that is often an attitude. But, I mean, the questionnaire is complicated, and it at the same time has to be simple. And we try to figure this out too, right? So with that questionnaire and with time spending with them, hopefully, some of the questions are aiming at that. They're basically saying, okay, did you really understand, first of all, aortic valve replacement and the option of TAVR? Did you really understand, yes or no, and then different grades of it? And at the same time, there's going to be questions like, I understood it all, but for me, the decision is I don't want to have any major interventions, right? So in this kind of way, we hopefully can, at least in the subgroup of patients that we're going to look at, address that question. I hope it comes out that way, that we can figure it out somehow, right? Is there some certain, is that really the main focus, or is it the insurance? Is it that you can't travel? Is it, what really is it? And how can we fix it, at least in our little community here?
Any other questions? Okay, thank you.
You know, I think our telecardiology program is one way where we've done well in addressing disparities in care, where we're going to serve communities that are further away from us, and I think a lot of those patients may not seek subspecialized care without an initial friendly encounter with a provider. And in that encounter, we have the opportunity to describe the clinical situation and educate. And even if we can't necessarily treat in the original encounter, I think a certain percentage of those patients do come and seek more advanced care here. So I think Mark should be applauded for developing that program, and I think it helps address at least economic disparities.
Yeah, I agree.
Okay, any other questions? Okay, thank you very much. Have a great week. Please stop by on your way out and thank Janssen Pharmaceuticals, Denise